I'm asked to chair this session, this poster session on implementation, and I welcome all the speakers in this session, and also all the attendees. And I want to introduce the first speaker, which is Jessica Matuoka from the Hospital Alemão Oswaldo Cruz. And she will present her poster setting the path for guideline implementation in Brazil, a pilot situational assessment study. Please, Jessica, you can start, I guess.
Thanks, Paul. I'm going to share my screen here. Can you see it?
Yes, we can see it.
So for me, it's such a pleasure to be here today sharing our experience with you. So I'm going to start by saying that Hospital Alemão Oswaldo Cruz has a partnership with the Ministry of Health for the development and update of clinical guidelines. And just recently, we started the process of monitoring the implementation. So here, I'm bringing to you our paper, Setting the Path for Guideline Implementation in Brazil, a Pilot Situational Assessment Study. So throughout the year, the Ministry of Health publishes several guidelines, but it is unknown how well these guidelines are disseminated and implemented in the Brazilian Unified Health System, which is a critical gap in knowledge. So the aim here is to assess how key stakeholders perceive the implementation of guidelines in state health departments in Brazil. So as we have a lot of clinical guidelines, at first we cannot evaluate all of them. So we asked state health secretariats in Brazil to point out priority issues based on the available guidelines. This contact was made through the National Council of Health Secretaries, CONAS, that is one of the partners in this project. So based on their answers, we elaborated a few questionnaires that included questions about comprehension, implementation, dissemination, pharmaceutical assistance, social participation, and judicialization. So out of the 27 federative units, 14 of them responded with theme suggestions for evaluation. These suggestions were taken to the representatives of the Ministry of Health for confirmation, and then 3 themes were prioritized, and they were the prevention of venous thromboembolism in pregnant women with thrombophilia, age-related macular degeneration, and rheumatoid arthritis. So we developed specific questionnaires for these 3 themes, but we also developed another questionnaire that is related for any Ministry of Health guideline in general, just asking different aspects of the guideline. So after validating the questionnaires, they will be sent to all federative units aiming at health secretaries, head pharmacists, physicians, and health managers. And each participant will have 2 months to answer these inquiries before we close the data collection and start analyzing the results. So this is a pioneer project and will show how well the federative units implement the guidelines issued by the Ministry of Health. And it is also a pilot study that will pave the way for more complex projects of evaluating the barriers and facilitators of the implementation of clinical guidelines in Brazil. That's all I have for now. Thank you.
Okay, thank you very much. I think there is some room for some discussion. Are there any questions? I try to see. Some questions. No, real. Yeah, I tried to see it. Sorry, but I have to fix here from one panel to the other one. If there are people who have some questions, they can put them in the panel now. I don't see any questions. Okay, then probably we can go on for the next presenter. Thank you, Jessica, for your presentation. Then there is Betty Cook from NIS, who will present on optimizing content for implementation in social care. Becky, could you?
Thank you, Paul.
Yeah.
Hopefully you can see me. I'm going to share my screen. I have a couple of slides for you all. So hopefully you should be able to see that now. All good?
Yeah.
Okay, so hi everyone, and thank you for joining me on this poster on optimizing content for implementation in social care. I'm Becky Cook, and I'm an engagement officer at the National Institute for Health and Care Excellence, or NICE, in the UK, based in England. So to give some background to this work, NICE produces evidence-based best practice guidance across health and social care. And whilst health audiences were familiar with implementing NICE guidance, when NICE was given the remit to produce guidance for social care in 2013, innovative implementation methods were needed. Our objective was to optimise our guidance content to support the sector to understand and use it. And to do this, we developed Social Care Quick Guides. Co-produced with the Social Care Institute for Excellence, or SCI, Quick Guides are short, accessible, leaflet-style guides which can be used in staff training, in conversation with people who use social care services and their families or carers, and by social care staff and registered managers to improve quality. So how did we create these quick guides? Using our knowledge of sector priorities and stakeholder feedback, we selected appropriate topics from the library of NICE guidance. We piloted 2 topics in 2016, and when these did well, we commissioned a further 27 quick guides from SCI between 2017 and 2021. To ensure the content was implementable for specific social care audiences, an advisory group was convened for each quick guide, with expertise from the Guideline Committee, relevant professionals, and people with lived experience. The advisory groups were invaluable in ensuring quick guides were person-centred, empowering, and supportive. For example, for the Enabling Positive Lives for Autistic Adults quick guide, shown here at the top in green, the advisory group fed back that the appropriate term for referring to people was autistic adults instead of adults with autism. We also worked with the advisory group to ensure the imagery and the pictures were appropriate. For example, for the Reducing the Risk of Violent and Aggressive Behaviours quick guide, shown here in the centre in purple, quotes were used on the cover rather than violent imagery to ensure the voice of the young people and their emotions was the focus rather than their actions. As a result, the 29 quick guides have successfully supported guidance implementation in social care. This quote in the top right from a social worker in Cumbria in the north evidences this. Available free online as an HTML or downloadable and printable as a PDF, the quick guides continue to increase in popularity. This graph here from Google Analytics shows the increase of monthly page views per quick guide between August 2020 in purple and August 2021 in blue. In addition to these successes, some quick guides have also been translated into Welsh by Social Care Wales, including Recognising and Preventing Delirium, shown here at the bottom in white, which is now Adnabod a Catal Delirium. If you'd like more information, you can download the poster from the portal or do feel free to contact me. Thank you so much for your time, and I'm happy to take any questions. Thank you.
Okay, thank you, Becky, for your presentation. Are there any questions? And from the audience? Perhaps first I can ask you a question, Becky. I like the presentation, certainly. If I understood well, it's meant those formats for the stakeholders, in fact, of a guideline. Is it also meant for patients as a stakeholder, or do you need another format?
Yeah, so when we're looking at developing a quick guide, think really carefully about the audience that's going to benefit most from the particular quick guide. And we base that on the guidance itself, so the original guideline, and also kind of this the audience within social care that we think would be best. So whether that's a manager of a care home, whether that's someone who's providing community services like in people's own homes, whether that's a social worker kind of doing an assessment, or whether that's the person themselves. So in healthcare, they would say patient, but in social care, we would say person or person with lived experience. So we have quite a few quick guides for like people who are going to buy their own social care, which is something that you can do in the UK. You get money from the council and you can buy your own service. So we have guides that do that. So really that whole spectrum, yeah, of those kind of different people that might be involved in some way in social care.
Okay, thank you. Are there, from the participants, I think you can also raise your hand normally, should be in the Zoom, but I'm not sure if that works. No any other questions of the people attending? I see that there are 28 participants, so I guess there must be some interesting questions. Okay. It must be very clear for the audience if I say. Okay, no other questions at this moment, Becky. So thank you for the presentation. And then
Thank you so much.
I will see for the next presenter. That's Marianne from Research Assistant from the Effective Basic Services in Africa, EBASE, and she will present something about using best practices to improve the health of young girls during menstruation in schools in sub-Saharan Africa, a case study in Cameroon. Please, Marianne, you come share your video and share your presentation. Okay, perfect. You can start. Marianne, we don't hear you. Yes, okay. See it now better. Yeah, that's perfect.
Marianne, can you come off mute, please?
Hello?
Yeah, we can hear you, Marianne.
Can you hear me? All right.
Okay, just start. Thank you.
All right. As I was saying, I'm Banks Mary Ann Zitem, a research expert and librarian at EBASE Africa in Cameroon, and I will be presenting a poster on using best practices.
Marianne, we lost your presentation, I guess.
Yeah, I'm having some challenges with internet. All right.
It's there again. Thank you.
Yeah, okay. So I'll be presenting on using best practices to improve the health of young girls during menstruation in schools in Sub-Saharan Africa, case study, Cameroon. So in my background, menstrual hygiene management affects schools' health, with 1 in every 10 girls not attending school during their menstrual period. There are no existing guidelines for menstrual hygiene management for girls of school-going age in schools or even in communities. And more than 70% of girls, according to UNICEF, have little knowledge about menstrual hygiene management, and girls do not discuss about their sexual health with their families. So for the objective is to improve girls' health through best practices in menstrual hygiene management in schools and in communities in some priority regions in Cameroon, that is in the Northwest, in the East, and the far north regions of Cameroon. And for the method, we'll be doing an evidence synthesis. And this is because we want to identify evidence gaps in menstrual hygiene management. And when we have identified these gaps, we'll be making recommendations based on best available evidence. Also, we'll be commissioning 1 pilot evaluation project, and we'll be using a cluster randomized control trial. So as you can see on my left, this is a snapshot of some of the mesh terms we have already developed on menstrual hygiene management. So when we develop these mesh terms, we then use it to search for papers in different databases like EBSCO, Campbell, Google Scholar, just to name a few. And for this search, I had 2,230 studies. That's the total hit I had, and 511 were duplicates. After screening on title and abstract, I had 96 included, and just 9 was being included based on full text. So after having this result, as I earlier mentioned, that we'll be developing recommendations, and these recommendations will be communicated to targeted population, and we'll be using what we have developed at eBase Africa we call Evidence Story Day, which is a concept where we use songs, poems, dance to communicate research evidence to targeted population, especially to the non-literate and the underserved population. And for the guidelines, we're encouraging best practices in menstrual hygiene management. And in doing this, we'll be delivering a dignity kit to adolescent young girls. And this kit will comprise of sanitary pads, soap, and pants, which they will use during menstruation. Also, we're encouraging revision of policy. We are encouraging the government to do a revision of health policy, especially on menstrual hygiene management, and also to be fully involved in the provision of menstrual hygiene materials to adolescent girls, recommending a more rigorous research to be conducted for menstrual hygiene management in Sub-Saharan Africa. Thank you very much.
Okay, thank you, Mengazi. We lost you somewhere, but mostly we could follow the presentation of your poster. Are there any questions at this moment? You can always put your questions in the Q&A. Yes, there is, I think, from Peter, a question. Peter, do you perhaps you can put it yourself. Do you see the recommendations you propose feasible in your country? Marianne, ma'am, could you have a response to that question?
Sorry?
Yeah, I saw here in the Q&A a question from Peter. Don't know if Peter is here.
Yeah.
All right.
Perhaps, Peter, you can unmute yourself and put your question yourself.
Yeah, that's maybe more easy. I had a question if you made some recommendations with your paper. I was wondering if you saw these recommendations that you proposed feasible in your country at this moment, and or what is needed to make it more feasible?
Right now it is feasible, but what we need more is resources to be able to deliver this dignity kit to the adolescent girls. It's very feasible in our context.
Okay, thank you very much.
Okay.
Yeah.
Other questions from the attenders? Okay, I don't think so at this moment. Okay, then you may close your presentation, Ghazi, Marianne, and thank you for the presentation. We go on with the next presentation, and that's Grace on More Life Mums B2B, I think, yes, sorry, it's a difficult title. You have to pronounce it yourself, I think, Grace. And you come from, you can also present yourself, you're online. Okay, can
cool. Yeah,
load
let
up
me
your
just
presentation.
share my screen with you all. Just have one slide.
Jojo will come and slap you there. Do you know how much you buy that thing? Jojo will come and whap your buttocks there before you know.
Sorry, can everyone see this?
Yeah, we can see it. Grace, you can start. Perhaps you can still put it in full mode, but
Yeah, sorry, when I do that, it goes to this.
yeah, okay, but then go back, we can follow it like that.
Okay, I'll just
Yeah, no problem.
blow it up.
Perhaps put, yeah, that's great, that's great, okay.
Perfect, thank you. So hi, my name's Grace. I'm a PhD researcher at Leeds Beckett University in the UK. And I also work for a commissioned service provider for weight management, More Life. I'm doing a PhD and collaborative project with my company, More Life, to further understanding in obstetric weight management and to develop a service and program based on research that is effective and flexible for pregnant women with excess weight to support them to have the healthiest pregnancy possible for themselves and their baby. So obstetric weight management is quite an under-researched area, and there's quite a lack of provision in the UK for services that support women with excess weight in pregnancy, especially commissioned services that would be commissioned by our local councils and would provide free provision for women. There's also kind of a consensus that previous services have been quite unsuccessful in engaging this population. There's quite a lot of barriers to working with pregnant women with excess weight. For instance, being unable to attend appointments, obviously maybe feeling tired or feeling sick, and therefore that's a barrier to engagement. There's also been a lack of success in maybe the content that people were delivering to this population as well. So as a company, More Life is a subsidiary of Leeds Beckett. So we invested in a PhD research project, which is mine. We're looking into obstetric weight management and the lived experience of women. But also what makes this study unique is that it also has included healthcare professionals, so we are able to further understand sort of the relationship between women with excess weight in pregnancy and maybe their relationship with healthcare professionals, and help to use that research to further develop the programs. So as Paul was struggling with, More Life has 2 programs that we are currently delivering across Bedfordshire and Milton Keynes in the United Kingdom. And it's Mums to Be, and that is for expecting parents. And we also deliver 4 Mums, which is for postnatal weight loss. It's really important to work and support women with their weight during these times, because it will help to reduce sort of the associated negative health outcomes. So for instance, if a woman has a BMI of 30 or above, they're actually more likely to have an unplanned pregnancy loss than someone with a healthy BMI. They're also more likely to develop gestational diabetes, which can have implications for themselves and their child later in life. So really just supporting them with excess weight is really important. The approach that we've taken to development was to be highly influenced by NICE Guidance, which is who Becky was referring to earlier and works for. NICE Guidance is a clinical governance in the UK, so we sort of were influenced by that and the recommendations that they had for working with this population. But we also combined that with focus groups, both with healthcare professionals and women. And we're looking at this ongoing research project to really feed in for quite a long-term period in developing the service and our work with this population to be as effective as possible. NICE Guidance in the UK suggested that you make it as flexible as possible, that you build as many relationships with stakeholders and partners like midwives. So we really took influence from that, and we've seen some really successful results. We have 80% of women who get referred to us from stakeholders take up the opportunity of our programs. We're also seeing statistically really positive results for them starting, engaging with us. And that's because we've really done things like making the appointments flexible, as NICE suggested, but also taking into consideration biopsychosocial factors with the content of our programs, and sort of acknowledging both psychological and social barriers to eating well and sort of looking after yourself in pregnancy. I think that's all from me today. Thank you.
Okay, thank you very much, Grace. There is a question in the Q&A from Becky. Becky, you can also come. You can unmute yourself and put your question yourself if you want.
Hi, Grace. Thank you so much for such an interesting presentation, and great to see you're using the NICE Guidance, of course, as well. I just had 2 questions. Firstly, I wondered kind of when you've been speaking to health professionals through your research, if you found that they have like quite a high awareness of NICE Guidance, or if they have quite a low awareness of NICE Guidance, and how you've kind of found that. And then secondly, just from a selfish perspective, I wonder if you're planning to feed the research back into NICE, because I know we're currently looking at the suite of guidance on weight management and how we're going to update that. So it sounds like you're doing really interesting things. But yeah, thank you so much.
Yeah, thanks, Becky. Actually, it was someone from your team who referred me to this conference, because we are published on NICE as an example of best practice for our Mums to Be and 4 Mums programs. And obviously have been working towards sort of building an evidence base that can feed into that. I know that you are updating them, and we're actually stakeholders on the panel for that. So we'll be putting some comments in on the draft and sending that in, which I think is a really positive process. And yes, when I've been talking to healthcare professionals, but not only healthcare professionals, but also commissioning bodies, everyone in the UK is very familiar with NICE. And uses them as guidance for delivery. So it's really good to use them alongside sort of research projects, but also obviously now they're getting renewed. I think it's a really positive. I noticed lots more information on maybe the psychological factors that might health professionals might need to consider when working with this population in the sort of newer stuff. And I think that's really important. I think it's such a valuable area to grow our knowledge in, and it's just great that it sort of has an interest, and people are really recognizing that this is an area that needs a bit of attention, including sort of NICE and ourselves and everyone in the UK. If that answers you.
That's wonderful. Thank you.
Okay, thank you. No other questions at this moment? No. Okay. Grace, thank you very much for your presentation, for the nice research. And then we go on with the next presenter. It's Jessica Matwoka, updating of the chronic pain guidelines in the context of the Brazilian unified healthcare system.
Yes, thank you, Paul.
Yeah, we see.
Can you see my screen?
Yeah, we see the screen. Yeah, the up of the screen. Perhaps you have to go down, but it should go down during the presentation. No problem.
Just a moment here. I'm just trying to find the presenter mode. Yeah, I'm having some difficulty here, so I'm going to present like this, but I'll scroll down the page so you can see it. So this is also a part of our partnership with the Brazilian Ministry of Health. And now I'm going to present the updating of the chronic pain guidelines in the context of the Brazilian unified healthcare system. So as you all know, chronic pain is one of the main non-communicable long-term conditions, and it significantly impacts lives and has high costs for the healthcare system. Here in Brazil, we have a current version of our chronic pain guidelines that is from 2012. So it is time for an update. So the objective is to present the update of the chronic pain guidelines for the context of the Brazilian unified healthcare system. So in order to get this project going, we held a scoping meeting with experts to discuss the concept of the chronic pain, its management, and on this day, we defined the extent of this project and aligned the expectations of different stakeholders. Also, 7 research questions were prioritized for 7 technologies for coverage by the Ministry for coverage by our healthcare system, and included diclofenac, topical NSAIDs, duloxetine, lidocaine, pregabalin, tramadol, and strong opioids for the treatment of chronic pain, depending on its indication. And here, the methodologists prepared 7 dossiers that followed several steps that I'm going to into detail later. So chronic pain here was defined as pain that lasts at least 3 months, and it was classified according to the most recent classification of the International Association for the Studies of Pain. For the technologies that were prioritized, we evaluated their efficacy, safety, through some steps that included the extensive database searches, the selection and data extraction, also data synthesis through pairwise and network meta-analysis. We also assessed the risk of bias and the overall quality of evidence. We also conducted searches in international health technology assessment agencies, and we also performed economic evaluations and budget impact analysis from the healthcare system perspective. So all this information was combined into a report that was presented to the National Committee for Health Technology Incorporation that makes recommendations about covering or not covering a certain technology. And after their initial recommendation, the report was sent to public consultation. The contributions were evaluated, and presented again to the plenary that made their final recommendation. Their decision and the report was corroborated by the Ministry of Health, and then the recommendations could be made and included in the guideline. So the continuous updating of guidelines is an important tool to assure the best care to patients, the best available care to patients, standardize medical management of a condition, and guarantee the system's sustainability. And that's what we expect to achieve with this new version of the guideline. Thank you.
Thank you, Jessica. I look for if there are some questions in the Q&A. Yeah, if I understood well, you have updated previous guideline also, and but I missed perhaps a little bit the timing. The previous guideline was from which date? Was how old?
It was from 2012.
Yeah. Okay. And so you update it now, and for the future, because probably pain management can change more rapidly than other things. Is this something you will update regularly, or going more to living guidelines?
Here in Brazil, we have some definitions about guideline updating. So we have to update a guideline by every 2 years, or if a technology is covered, a new technology is covered by the healthcare system. So that's what we intend to do. Okay, that's fine. That looks great. Any other questions of okay. Yeah, it's interesting because perhaps we have to look also to your guideline, because we are probably planning next year also updating of our pain management guideline in Belgium. So it would be great to see what's come out of your guideline compared to the updating of our guideline. So that's nice contact. Okay, thank you for your presentation, Jessica. And then we go on to the next presenter, which is Elaine. Yeah, Elaine is somewhere here. Yeah, okay. Evidence-based practice at the point of care in the palm of the nurse hand, facilitating best practice guidelines for person-centered care. Please go ahead, Elaine.
Thank you very much. And my presentation is tape recorded.
Yeah.
Hello, my name is Elaine Santamina, and welcome to our poster, BPGs in Action, a web-based strategy to support guideline uptake for nursing. My colleagues and I from the Daphne Cockrell School of Nursing, Ryerson University in Toronto, Canada, would like to share our innovative web-friendly intervention to implement 3 best practice guidelines, or BPGs, from the Registered Nurses Association of Ontario. Informed by findings from our guideline implementation gap analysis study, we identified inaccessibility and time constraints as challenges to guideline implementation for nursing students and nurses. Our team of faculty researchers collaborated with our communication creative lead and undergraduate and graduate nursing students to create a student-driven solution to implement the 3 priority guidelines: fall risk assessment, pain assessment and management, and client and family-centered care. Nurses download our free mobile-friendly intervention, seen here on your screen, on their own handheld devices to have guideline implementation support at point of care and in the palm of their hands. Our BPGs in Action site includes the basics, or a primer, in evidence-based practice and best practice guidelines, all BPGs with easy access and organized in a way that is meaningful to nurses in practice, point of care resources for person-centered care, pain assessment and management, and fall risk assessments. We include practice resources presented in the context of care provision while the nurse is wearing personal protective equipment during pandemic precautions. In addition, our students have created audio-video recordings of case studies in which they have actually implemented one of these recommendations from the guidelines. Our next steps include development of additional student-generated case studies, broad dissemination across nursing programs and our clinical partner settings, in addition to measurement of uptake and reach. Please download BPGs in Action on your handheld devices and share it across your healthcare communities. Thank you for attending our poster presentation.
Okay. Thank you very much, Elaine, for the presentation and recording of your presentation. I look at the chat and at the Q&A if there are some questions. Yeah, I see Julie, but I guess, Julie, that was for the previous presentation. Probably, yeah. Any other questions for Elaine at this moment? It was all clear by your presentation.
Maybe I have a question.
Yeah. Okay, you can.
Yeah, because I may have not understood it very well, but you developed these things, but did you also try to evaluate them on nurses themselves, or are you planning to do so?
That is our next steps. So we have been using them in clinical courses at the moment, and also in some of our research and theory-based courses. So our next step is the evaluation of uptake and how effective it is for nurses actually at the point of care. So we'll work with our student nurses to do that evaluation, and then also nurses in practice.
All right, very interesting, thank you.
And then there is also from Becky a question. Do you find nurses are comfortable with the technology, or was a lot of training needed?
Nurses are actually quite comfortable with the technology. Most of them do have handheld devices of their own. And most of our students at least, are using a lot of technology because all of our programs and courses have been completely online during the COVID pandemic. So we find that they're actually quite tech savvy, probably more so than many of us profs would be. And so at this point in time, there has not seemed to be a problem. They can use it on any handheld device, so it doesn't have to be an iPhone, it could be Android, they could use it on their iPad or their computer, whatever they find easiest. It could be downloaded on the computer in the nursing station as well if they wanted to do that. So far we've not heard of a problem, but that's certainly an important part of our evaluation.
Okay, thank you. At this moment, no other questions. Okay, thank you, Elaine, for the presentation and answering the questions. And then we go on for the next presentation of Catherine Wallace about the Leading Change Toolkit. So Catherine, could you come unmute yourself and upload your presentation or poster?
Thank you, Paul. Are you able to see my slide?
We can see it.
You want me to
yeah.
Okay, so thank you, Paul, and thank you everyone for the opportunity to present my poster on the Leading Change Toolkit, an evidence-informed implementation resource for lasting improvements in healthcare. My name is Catherine Wallace. I'm a Senior Implementation Manager at the Registered Nurses Association of Ontario, where we produce best practice guidelines, and ironically just presenting after Professor Santamina, who is also talking about RNAO best practice guidelines. So we have just recently released a brand new implementation resource. And this resource is meant to support change agents in their implementation of guidelines, including RNAO's best practice guidelines. The Leading Change Toolkit includes 2 frameworks to support implementation. And we know that frameworks can guide, like compass, a change initiative. So we created the novel Social Movement Action Framework in the toolkit, as well as from our second edition of our toolkit, the Knowledge to Action Framework developed by Dr. Ian Graham and colleagues. So first, a little bit about the Social Movement Action Framework, and our poster focuses on the methodologies that we use to support the entire toolkit. So the Social Movement Action Framework that you can see depicted on the left-hand side was developed from a concept analysis. We wanted to study social movement action in the context of knowledge uptake and sustainability and what that meant. As a professional association for nurses, we've used social movement action to support and mobilize change to transform nursing and health outcomes. We want to study it specifically in the context of knowledge uptake and sustainability, including the uptake of RNAO's best practice guidelines. So we did a concept analysis in which we studied social movement action. We used the Walker and Avant method. And from that then, from title abstract and full text review, then found examples of social movement action in this context. Through data extraction then, we found examples, and that allowed us then to formulate 16 unique elements that characterize social movement action, and we use those results with input from our expert panel, who are also co-authors on this poster, to formulate then the social movement action framework that you can see depicted that includes the preconditions, key characteristics, and the outcomes. So social movement action framework, that can be combined with the knowledge to action framework, a framework that I suspect many of you on the call today are familiar with. For this work then, we updated the literature and included that in the toolkit. What's novel here is that we made linkages of the action cycle phases that make up this framework to social movement action for the change agent then to be able to use and integrate elements of both frameworks to support a change initiative and to accelerate success. We also did a study of tools, valid and reliable tools that could be applied to some of the action cycle phases. And for this work, we screened tools for title abstract and for full text. And then a working group did a review in which they studied the tools first for their pragmatic quality. So we asked stakeholders to review the tools and determine whether or not they were easy to use, were they compatible with their sites, were they tools that realistically they could use in clinical care to support the implementation of best practice guidelines. Following pragmatic review, then there was a review for content validity. And then the tools then that met our inclusion criteria from that, then we mapped those to the action cycle phases. And that work, again, done by a working group that was part of our expert panel and included our co-chair, Dr. Janet Squires, as well as one of our expert panel members, Dr. Ian Graham, who, again, is one of the developers of the Knowledge to Action framework. So in the Leading Change Toolkit, anyone is able to access this content, and you'll be able to see examples of tools that can be considered for applying during the action cycle phases, and includes a summary of the tools, where open access, then access to the tool, as well as details regarding the pragmatic and content validity of the tool. Finally, the third component of the Leading Change Toolkit is regarding engaging persons with lived experience. And that you can see in the graphic on the right-hand side. And it's really how do we most effectively engage persons with lived experience in our change initiatives, whether they're part of our change teams as formal partners or more in an informing or consultative manner. And so from this work, then we did a literature review and determined a number of strategies, tools, and approaches to most effectively engage persons with lived experience in change initiative and to apply principles of person and family-centered care as part of this work. So in conclusion, the Leading Change Toolkit available on the RNAO website, available to anyone, currently available in English, but will be translated in the future in French, Spanish, and Chinese, and perhaps other languages. So rnao.ca/leading-change-toolkit. Thanks, Paul.
Okay, thank you very much for your presentation, Catherine. And again, I think an interesting toolkit presented by the ERNIO from Ontario. I look in the Q&A if there are some recent questions. Yeah, Becky again. Yeah, Becky, perhaps you can unmute yourself if you want to put a question here also. We find it certainly very interesting. So,
thank you.
Yeah, thank you, Catherine. I found that really, really interesting. I just wondered if you would be able to say a little bit more about what works for you when engaging with people with lived experience, and if there are any techniques that you found really helpful or any particular approaches, because I think that's really key to kind of embedding change, certainly from my kind of perspective. I think that makes such a difference. So yeah, thank you.
In the toolkit, then we have a section on how to get started. And one of those sections focuses on staff's readiness to engage persons with lived experience. For myself as a nurse and for other healthcare providers, it's a shift in thinking from seeing persons with lived experience as the patient, as the recipient of care, to someone being actively engaged in your change initiative. So part of that is a reflective process in which you're examining beliefs regarding what perspectives do persons with lived experience, what do they bring, and am I ready, am I accepting of those individuals to be part of a change team? That's part of what you'll find in the toolkit, and we have a worksheet that has a number of questions for reflection to guide that process. We also talk about engaging advisory councils as part of this work, and recognizing as part of social movement action the value, the importance of direct experience, and as informing the change and the urgent need for change. And so those recipients of care certainly are the ones who have the most direct experience. So it's really a valuing of those individuals, their perspectives, and trying to use that to drive change that's driven in values.
Thank you, really interesting.
Thanks very much.
okay. Yeah, there is still, yeah, Ambang raised her hand. Perhaps you can unmute yourself and put the question still.
Okay, thank you, Catherine, for that wonderful presentation. I want to ask if this toolkit, there is a possibility of transferability to other contexts. For example, if you can be able to work in the African context.
Thank you for that. Yes, we part of the reason that we've made the Leading Change Toolkit available online is to increase accessibility. If there are other languages that we can translate it to extend the reach, we certainly would be interested in that. I believe in the abstract or on the poster, you'll find my email address, kwallace@rnao.ca. So certainly if you think there's an interest, please let me know. It is our plan, in addition to the online resource, to also create, probably in the next 6 months or so, a printable resource that'll be sort of a condensed version, because it's quite a large resource with 2 full frameworks plus the section on engaging persons with lived experience, and that we will look at translating into even more languages as a way then of supporting sites using RNAO best practice guidelines and other guidelines to effectively lead change. The social movement action, I think, is so applicable. It really focuses on how do we as frontline care providers, how do we engage and develop that leadership so that we are a part of change in meaningful ways. So thank you for the question. And yes, again, please reach out via email to let me more of what your needs would be. We certainly want to make it as accessible as we can globally.
Okay, thank you, Catherine, for answering those questions. Interesting presentations, thank you. And then we go on with the next presentation of Peter van Bostraten, user testing of BMG rapid recommendations in primary care. Please, Peter.
Yes, thank you very much. I'll try to share my screen. Okay, are you seeing my screen?
Yes, we're seeing your screen. Perfect.
All
yeah.
right.
Okay.
So, hello everyone. My name is Peter van Bostraten. Together with 4 other general practitioner trainees, I export the user experience of Belgian GPs using the BMJ Rapid Recommendations infographics under supervision of Professor Mieke Vermande as part of our master thesis program. The Rapid Recommendations infographics, of which you can see one here on the left. I'll try to zoom in a little bit so that you can see. Okay. They are a visual presentation of an evidence-based recommendation, and they try to answer the need for better guideline implementation by being understandable and easy in use. Little evaluation regarding the user experience had been taking place before, so we conducted a mixed methods iterative user testing with 5 translated infographics and with 10 general practitioners in one phase. Oh, I think okay, like this you can see it again. So with 10 general practitioners in one phase, and then again 10 general practitioners in a second phase after we refined the initial infographics. We were able to draw the most important observations into 6 categories, which you can find here on the right in our results. So overall, GPs were very positive about the infographics. For the rest, I'll go with you through the most important ones. You feel free to read the whole poster afterwards, so send me an email, which is above in the poster as well. So GPs found the infographics to be very simple in use, time efficient, also very easy to understand. The preference for an interactive version was very clear, and when scales are used, they should be clear and commonly used in daily practice as well. The GPs liked the topics, and the infographics supported the shared decision-making process, which is very important, a very important goal of the infographics. It is, however, depending on the type of patient. More controversial topics like screening for prostate cancer, for example, was less adhered to, and also we saw that local adaptation is also absolutely necessary for adherence. Desirability layout was perceived positive overall. Uniformity between all infographics was preferred, and a more straightforward color scheme is also preferred with not too much different colors. We facilitated in the second phase an integration of the infographics in the electronic health records, and this was a major asset to the general practitioners for findability, as did it help to give the interactive version to them, which was preferred also when we are talking about accessibility. And then credibility, the infographics were very trustworthy as they came from BMJ, which is very known in Belgium, and they were found in the electronic health records that also added to their credibility and trustworthiness. To conclude, we can say this about the user experience of the 20 Belgian GPs that we interviewed about the infographics. They are very useful tools in primary care. GPs are mostly positive. They should not be too crowded and use a straightforward an interactive format is definitely preferred. Infographics should be easily accessible. And we saw, for instance, through the electronic health records, that's a good option. And also barriers to adherence should also be very studied to and accounted for in the future. Okay, I thank you for your attention, and I am ready for questions if there are any.
Okay, thank you, Peter, for the interesting presentation. Are there any questions? Okay, Brittany, how are the infographics integrated in the electronic health record? Is that something which you can explain?
Yes, very interesting. Well, in Belgium, we use Care Connect, which is a medical electronic health record, and we have like an evidence linker in it. So that's just a simple button. When you code a diagnosis, you can click on the evidence linker, and then you get redirected to a database, a Belgian database, EB PracticeNet, which is made up in Belgium with a lot of national and international guidelines. And there we all made the infographic. So it was like 2 clicks away from when you coded the diagnosis. Thank you for the question.
Okay. Okay. Ambang, you have also a question. You can perhaps unmute yourself.
Yes, I was asking if these infographics are actually used in testing remotely. Like, can somebody use the infographics to be able to have a result of a test remotely?
I do not quite understand your question. Can you rephrase?
I was asking if these infographics are actually used in healthcare facilities. Like, for example, can a doctor be able to get a sample from a patient and be able to get test the patient from what the patient is suffering and get the result remotely?
Yes. So the infographics are freely available at this moment, mostly in English. Right now, when you like search on Google BMJ Rapid Recommendations, you can go to their website, and there a lot of times there come new ones that are being made, and they are until now still free in use. So you can just open up your computer and access them, if that's an answer to your question.
And I see still raised hands. Is that true from Bangisi, Marianne? Do you have a question for Peter too?
All right. Thank you very much, Van, for your presentation. I wish to ask if these infographics are accessible to people with disability, if they can easily access them.
Well, it's depending on which disability. What's important about these infographics is that they are meant for doctors, for general practitioners, not for the patients. We have shared decision-making or shared decision-making tools as well that are linked to the infographics, but these are made for doctors. Well, they are online, so it is not accessible for blind people, for example. What they tried to do was to make the colors are correct for the colorblind, so that they can access and read it easily. And I think with the interactive version, you also need to have some knowledge about working with the computer, all these things. We saw that most of our general practitioners were able to do so. So I think they tried to, the BMJ Rapid Recommendations tried to account for disabilities when it's possible, of course. But thank you for the question.
Okay, thank you, Peter, for the presentation and for answering the questions. And I have to introduce myself, and I will also share my screen. Okay. Do you see the presentation? I hope so. Okay, my name is Paul van Rooyen from the Belgian Working Group of Development of Primary Care Guidelines in Belgium, and I present this poster together with people, Martin Goossens, also from the working group, and Julie Christens, who is also present here, I guess, and Thomas Janssens from the EB PracticeNet in Belgium. In fact, we have in Belgium a network, evidence-based practice network, responsible for guideline and implementation. following the whole cycle of prioritizing guidelines and then developing guidelines, looking for the right indicators for evaluation, but in the meantime also looking for implementation. And EB PracticeNet is the core partner responsible for the guideline implementation. The working group of primary care guidelines is one who is responsible for the revision and development of evidence-based guidelines. As we have, in fact, minor resources, it's essential to see how to collaborate within this network. And one of the objectives of this part of this presentation is, and of our work, was to identify really the milestones for involvement of implementation experts within the guideline development process, and to define a procedure for identifying and addressing obstacles for implementation. As already presented, I guess also in the plenary this afternoon, it's really important to have implementation together with the development. But of course, you can't do it the whole time. So one of our priorities was to see where are really the milestones in that development process, where in the development of a guideline, the people of implementation experts should be present and work together with us in developing a good implementation plan. And then we saw during the whole process, and you see it a little bit in the middle of this poster, that there are in fact certainly 3 important steps where the implementability is important. In the steps where we go from evidence to decisions for recommendation based on the evidence, where you have to see whether there are barriers, obstacles, and so on for implementation of these evidence-based guidelines. In the formulation of propositions to be submitted for evaluation in a consensus procedure, that means if we have no evidence and we have to make a consensus procedure, it's important also to look at implementability afterwards. And of course, if we consult the stakeholders afterwards, it's also an important issue to look for what's the context? Well, how can we analyze the context, identify obstacles and barriers, and so we can develop an implementation plan. At this moment, that's our plan. In fact, it's a presentation of what we have developed now together with our 2 organizations, Working Group Development of Primary Care Guidelines, together with the EB PracticeNet. And we are now implementing the milestones in the development of guidelines on emergency medication and on postpartum care. And of course, we will see if that works much better to address the implementation challenges who will be there after, at the moment the guideline is ready and ready to be implemented in daily care and in primary care. So this is an embedded approach, and it will allow us to have more implementation during the guideline development. The same we have done for the indicators and the evaluation procedure, as well as the implementation, as well as the evaluation of guidelines implementation is already planned during the development. And that's a major step towards really developing an ecosystem of EBM in our country, what I think it's a major achievement at this moment. Okay, that's it for now. I'm open for some questions if there are some questions. Any questions from the audience?
I did put it in the chat, but I'm not sure if you can see it.
I try to follow all things. Do you consider, resource impact throughout at the same time as addressing implementation challenges, or are these issues considered separately? No. In fact, we try to to have at the same time looking at the impact, because of course implementation is not only knowledge to the practitioners, but it's also a matter of resources and systematic of system changes. So that has been done previously. It was something we did after the implementation or after the exportation of the guidelines, and at this moment it's really already covered during the guideline development, and I think that will be much more important, certainly in for the systematic. Of course, there is a delay always in structural changes. It's not always easy. The payment systems in the country, structural system of healthcare will not always change as immediately as planned, but at least it's important to plan it and to consider it at the same moment as we are developing guidelines. Okay, any other questions? No, at this moment, no. Okay, thank you very much for your interest and questions. And then we go on for the next presentation. That's from Ambang, Tatiana Forkum, on using formative research and social marketing to decrypt and fix the WIC problem in a conflict-affected areas in Cameroon. Okay, Ambang, can you unmute yourself and load up your presentation? Okay, fine. Can see it. Yeah, you can see.
Okay. So this project is about fixing and decrypting the wicked problem in conflict-affected areas in Cameroon. In our background, sexual and gender-based violence has really been a major threat to the development of the girl child. And in Cameroon, 2 in every 4 girls have experienced in their lifetime sexual and gender-based violence between intimate partners, and 1 in every 3 girls have experienced intimate partner violence in the last past 12 months of their life. And 3 in every 10 girls are married off underage, and there is a 1% prevalence of genital mutilation in Cameroon. And from this, our statistics was taken from the National Institute of Statistics and also from UNICEF 2018 and 2017. So our study contextualizes the use of clinical guidelines in the treatment and handling of the increasing rate of sexual and gender-based violence in our community. Our objective was to explore the barriers to implementation of clinical guidelines for sexual and gender-based violence at health facilities in Cameroon. As method, we did a rapid review, and then we did a qualitative research method, which we did key informal interviews, focus group discussions, in which we developed cross-sectional semi-structured interviews for clinicians, community health workers, and patients on the use of clinical guidelines. And then we did capacity building for community health workers and district health workers on the use of clinical guidelines. We also developed a cyber health platform, and we supported clinics and district health with post-exposure prophylaxis packages, and we supported some victims with psychosocial support and legal support if they are willing to pursue the case. So for our rapid review, we did a number of search, and we had high hits, especially in Google Scholar, for which we took the first 20 articles, the first 200 articles. And also we selected the 23 articles from the UN database from which we selected the Interagency Clinical Management Guidelines because it best suits the context in which we are working in, that's conflict context in which we are working in. And so far we have done 10 interviews and we identify key barriers in the use and implementation of guidelines. We noticed that clinicians were actually aware of these guidelines on sexual and gender-based violence, and they actually used these guidelines. But on the other hand, community members expressed some challenges in visiting hospitals, and we classified these challenges under 6 themes. We had stigmatization, fear of exposure of the perpetrator, attitudes of some clinicians in receiving victims. Some people were ignorant of the free post-exposure prophylaxis packages that were available, and they had inadequate confidentiality. They were scared that when they go to the hospital, their vital information may just spread out. And then due to the conflict in some areas, there was inaccessibility to healthcare facilities. So our approach is that we are going to we developed a cyber health platform, which is an innovative approach that uses mobile phones, crowdsourced data, and artificial intelligence within a community. This app is able to connect victims from the privacy of their phones to emergency, social, legal, and medical care. And this app also can provide guidelines for clinicians, create awareness on the guidelines of SGBV, and also help victims to be able to report cases of SGBV. This app also, we will use it to be able to tell stories and community experiences anonymously so that we can be able to bypass the stigma that most victims face and also maintain the confidentiality of victims of SGBV. Thank you.
Okay, thank you, Ambang, for your presentation. I'm looking for some questions or QA, or if somebody wants to raise a question, you can raise your hand also. Not yet at this moment. If I understood well, among the innovation technology and the best practices already implemented now at this moment, or is it just planned, and how do you evaluate the implementation of it?
Okay, the cyber health platform has just been created, so we are still doing the evaluation and we are still doing the implementation of the platform. Like, we're still creating awareness about the platform so that people can be able to use it and give us feedback about this platform.
Okay. So results will come later on, more and more. Yeah.
Yes.
Yeah. Okay. Any other questions at this moment? No, I don't see any other questions. So thank you for the presentation, Ambang. And then we go to the, I think, the last one of this session, Ain Soon Singh.
Thank you, Paul.
Yeah, it was a pleasure. Thank you. Ain Soon Singh, can you unmute yourself and upload your presentation? Monitoring of the cognition and connection parts of digital guideline in Korea.
Can you?
We can hear you, yes.
How about this slide?
Yeah.
You
Can you?
see?
Not yet. You have to share your
Not yet?
screen. In the meantime, I still see a question to Ambang of Ayrton. How do you guarantee a safe delivery for the patients? Is that something you can answer also?
What was the question?
Yeah, how do you guarantee a safe delivery for the patients? That's something, I don't know, Ayrton has put that in the Q&A.
Is it safe delivery of data or safe delivery of, I don't really understand the question well.
No, I'm not sure. Yeah, I'm not sure if Ayrton
Okay.
is here, but okay, perhaps you have to look in the Q&A and answer it directly.
Okay.
Einsun, you
Yeah,
can share
teacher,
your presentation.
I could not upload this the PDF file. Anyway, my name is In-Sun Shin. I am research head in Korean Academy of Medical Science in Korea. My presentation topic is the monitoring of the cognition and connection paths of digital guideline in Korea. PC and mobile version, two types of digitally structured guidelines for primary care physician has been developed in Korea for the first time in 2019. So the demand for dissemination of digital guidelines are increasing among end users. So unfortunately, there is only a Korean version and no English version. This study objective is to monitor the access of and utilization of the digital guideline by nationwide implementation strategy. There were 5 types of implementation strategy to monitor Korean digital guideline. First strategy was developing leaflet to explain how to use digital guideline and distribute them online, such as webzine, e-newsletter, and social network service. Second strategy was registering search terms on portal site, Google, Naver, and Daum. And the third strategy was installing banners at the web pages of Korean Guideline Agency and Korean Physician Association. The fourth strategy was disseminating information at the nation conferences for physicians. It is on-site spreading. The final strategy was mailing the information to the public center nationwide and Korean Physician Association. Let's take a look at the actual data. Following monitoring data provided by Google system from January to December 2020. The number of new visits was 8,471 and revisit was 1,016. Pharmacotherapy page visits were the most frequent. It was 70.6%. The connecting device were followed by desktop 74.1%, and the mobile 24.3%, and tablet was 1.6%. The connection paths are as follows. Direct access was 82.6%, Naver search was 5.6%, and Google search was 2.4%. The combination paths are follows. Conferences 33.3%, searching 28.9%, Replit was 16.9%. So we can confirm the strategy spreading on-site at conference for physicians was most efficient among 5 strategies. However, recently, because of COVID-19 pandemic, now we are switching from on-site dissemination to mailing or the video conference meeting. Based on thorough monitoring of the cognition and connection paths of digital guideline, all 5 types of implementation strategies proved to be working. Therefore, guideline implementation strategy should be planned comprehensively. It would be end of my presentation. Thank you. I'm sorry, just could not upload the slide.
Thank you for the presentation. So, I think Peter uploaded your poster, and thanks for that. So we could see it all and we could follow it. I don't know if there are some last question because we are at the end of this session almost in 1 minute. Are there any questions? Nice to see that there is indeed several implementation strategies working together. So that's, I think, a good example. No other question at this moment. Okay. Thank you, Aysun, for the presentation. And so we came to the end of this session. Thank you for your collaboration because I had to replace the moderator and fill in as a moderator. We are perfectly in time, I guess, because it's almost in 36 seconds the end of the session. We all managed it. Thank you for the collaboration and success at the other days of our conference. Thank you.
Thank you.
Thank you.
Thank you, everybody.
Thank you
Thank you
very much.
Thank you.